Today, we are going to talk about global and policy perspectives on culture and health. This is the fourth and final module of the culture and health course. We have spent this course exploring how culture shapes health, both at the individual and at the community level. But at this stage, I'd like for you to consider, as we close this course, that culture doesn't stop at the borders, and neither do health challenges. Health transcends borders, both because of the free movement of pathogens, as well as through the exchange of solutions that are developed collaboratively in order to address all sorts of diseases. A respiratory virus that emerges in one country has the ability of circling the entire globe in a matter of weeks. And we became vitally aware of that during the outset of the COVID-19 pandemic. Migration patterns shift healthcare needs in cities thousands of miles from where journeys began. Likewise, policies that are developed in international hubs like Geneva or Washington or New York can ripple across clinics in rural Guatemala or the shanty towns of Lagos, Nigeria. We live in a highly interconnected world. And yet, our health systems often operate as if culture were a local issue, something to address at the community health center, not the global policy arena. This is why, in this final module, I want us to challenge that assumption. We are going to examine how global health trends, including migration, pandemics, policy frameworks, all of these intersect with cultural factors. And we're going to ask a harder question. How can we define health policies that actually account for cultural diversity instead of treating it as an afterthought, if at all? If you're going to work in public health at any level, you will undoubtedly encounter these tensions. Local programs operate within national policies that are shaped by global forces. Understanding that landscape is essential. So let's get started. Let me frame what we're going to do in this lecture. I want us to step back from the individual clinical encounters and community interventions to look at the larger systems that shape health outcomes. This includes migration patterns, pandemic response, comparative health systems, and the policy frameworks that either enable or obstruct culturally responsive care. This isn't meant to be an abstract reflection. Instead, every policy decision, from how interpreter services are funded to how vaccines are distributed, carries cultural assumptions. Often, these assumptions reflect the experiences of whoever defined the policy, which means that they may not fit the populations most affected. Our goal today is to make those assumptions visible. Once you can see them, you can challenge them. Let's start this process by looking at migration. When people move, whether it's across borders or across a continent, they carry with them a set of health beliefs, practices, and values. What I'm saying may sound like a truism, it may seem obvious, but healthcare systems often act surprised by it. A hospital serving a neighborhood that has become the home to Somali or East African refugees may find itself navigating unfamiliar expectations about family involvement in medical decisions. A clinic in a newly diverse suburb discovered that standard diabetes education materials don't resonate as expected with patients whose dietary traditions are completely different from the assumptions built into the curriculum. We have a quote here from Glenn Flores. Glenn Flores is a pediatrician whose research has shaped how we understand language barriers in healthcare. And this pediatrician documented that limited English proficiency correlates with reduced preventive care, more emergency department visits, and overall worse chronic disease management. This is not because patients don't care about their health, clearly. It's because the system wasn't designed for them. So there's a misalignment between the system design and community needs. Addressing this misalignment required more than simply goodwill. It requires having trained medical interpreters, not children that are obliged into service translating their parents' diagnosis. It requires culturally appropriate education material that are developed with community input, not translated as an afterthought. It also requires intake processes that don't assume that everyone navigates bureaucracy the same way. But migration should not be viewed only in terms of challenges. A lot of solutions are generated through the exchange of ideas. In fact, cultural exchange can bring about great opportunities. When you have complementary and alternative medicine practices that originated in one cultural context, such as acupuncture, herbal tradition, mindfulness practices that are rooted in Buddhist contemplative traditions, all of these have become integrated into healthcare systems globally. And there's a growing body of research demonstrating the value of these practices, even when considered from the scientific method of experimentation that was born out of Western civilization. This is why the flow of innovations goes in several directions. The question for us is whether healthcare systems approach this exchange with curiosity and respect, or with resistance and dismissal. The answer to this question shapes whether diverse populations trust those systems enough to use them. Let's talk about pandemic preparedness. Because nothing in recent memory exposed cultural fault lines like COVID-19. This pandemic revealed something that public health professionals can sometimes forget. The ways in which people respond to a health crisis is not determined solely by the science. It's shaped by trust in government, historical experiences with medical institutions, community practices, and cultural frameworks for understanding risk and uncertainty. Cynthia Cheng and colleagues in 2023 conducted a remarkable study that examined coping styles across 44 countries. This was done during the first wave of COVID-19. And her team found that cultural dimension significantly moderated how people coped with the crisis. Problem focused coping, actively addressing the threat, seeking information, taking practical steps. All of this was generally associated with better mental health outcomes. Conversely, avoidant coping, denial, distraction, refusing to engage with the threat, all of these correlated with higher anxiety and depression. So perhaps there's no surprise here. But here is where culture played a key role. You have a categorization of countries depending on different dimensions. And one of these is whether they are more comfortable with uncertainty and open to ambiguity, or whether they avoid uncertainty and seek stability. So, given that distinction, those countries that were more comfortable with ambiguity often saw society seeking out support for improved mental health. Whereas in countries with higher uncertainty avoidance, that same openness sometimes increased anxiety. The same coping behavior worked differently depending on the cultural context. Now, I want you to think about what this means for pandemic communication. A message that resonates in Sweden might backfire across the world in Japan. An approach that builds trust in Brazil might instead generate suspicion in Germany. This is why one size fits all public messaging just isn't an effective way to advance health outcomes globally. Instead, it can actively harm by triggering culturally specific anxieties. During the COVID-19 pandemic, hesitancy varied enormously, not just between countries, but within them, across communities with different historical experiences. Nambi Nduga and colleagues at the Kaiser Family Foundation tracked this in the US context by showing how mistrust rooted in events like the Tuskegee study shaped responses in Black communities, while immigration concerns and logistical barriers were more salient among many members of the Latinx population. But this pattern isn't unique to the US. In France, there was also significant hesitancy linked to long-standing skepticism about pharmaceutical companies. Meanwhile, in parts of Africa, colonial histories of medical exploitation helped or ended up shaping responses to Western developed vaccines. In each of these cases, hesitancy wasn't an irrational response. Looking at it as irrational can be a form of cultural disrespect that is a disservice to better aligned, more relevant, and more effective interventions. Instead, we need to analyze these responses in a more comprehensive way. And we'll come to realize that they generally reflect rational responses to both historical and ongoing experiences. Thus, effective pandemic responses require understanding these cultural currents before the crisis hits. That way, we can avoid scrambling to address them in the middle of an outbreak. And what applies to a pandemic applies equally to other major public health endeavors. One of the most instructive exercises in global health is comparing how different countries approach the same challenge. These differences reveal cultural assumptions that we might otherwise never notice. Let's take mental health policy. Odilibe and colleagues published a comparative analysis in 2024 examining mental health systems in the US compared with several African countries. The contrast that they found was quite striking. Based on their study, the US approach emphasizes integration of mental health into general healthcare. This includes parity laws, insurance coverage, and clinical treatment models. There are real strengths here, but it's not a one size fits all. There may also be high costs, workforce shortages, and the persistence of stigma in healthcare settings that keeps people from seeking out care even when it's theoretically available. In contrast, some of the African countries that they examined display a different approach. They are experimenting with community based approaches that incorporate traditional healing practices. So rather than fighting stigma by medicalizing mental health, these models may work within existing cultural frameworks. They may do so by engaging traditional healers and community structures. So accessibility improves because care happens in more familiar and trusted contexts. This is a bit similar to my experience leading Heartland Alliance International in Colombia in predominantly Black environments, where we found that it was more effective to deliver services in community spaces and with a model that was validated by the community with the accompaniment and collaboration of community health workers than by transporting persons to a clinical setting that unfortunately was unavailable in these urban spaces. They would have to go to a faraway city, even though that was required for more serious psychiatric needs. The vast majority of psychosocial needs, including moderate to mild depression and anxiety, could better be treated in these community settings. Neither of these approaches discussed before is universally superior, but comparing them can reveal that our assumptions about how mental health should work are culturally specific. They are not scientifically inevitable. Social Epigenetics offers another lens for understanding health disparities across populations. Terry Martin and colleagues at the National Institute of Environmental Health Sciences published an important review back in 2022 that argued that social determinants of health, including racism, socioeconomic position, and neighborhood environment, they all affect health through biological pathways. Experiences of discrimination and chronic stress don't just make you feel bad, they can actually alter gene expression through epigenetic mechanisms, shaping health trajectories across the lifespan and potentially even across generations. This connects back to what we discussed earlier in Module 2 about the intergenerational transmission of trauma. But here, the emphasis that we want to make is on the policy implications. If social conditions biologically embed themselves, not just in minds, but also in bodies, then addressing health disparities requires addressing also the social conditions themselves, not just providing better medical care. Policies that reduce discrimination, improve economic opportunity, and create healthier environments aren't peripheral or complementary to health, but they are instead foundational. Now, let's move on to discuss intersectionality, which we've talked about a bit in the previous lectures. Intersectionality helps us see how these factors compound. Rocio de la Garza, in a fairly recent work in 2024, looking at intersectionality in education and health contexts, emphasizes that social identities don't exist in isolation. Instead, race intersects with class, which intersects with gender, which intersects with immigration status, as well as with the psychosocial framework of the individual, including any trauma history. Each of these intersections create unique vulnerabilities and unique strengths. This allows us to see more than a one-dimensional policy would account for. So designing policies that actually reach people requires understanding these intersections, not just addressing one dimension or one axis at a time. Okay, so far we've established how culture matters for health, that disparities are real, that policies often miss their mark. The question that we're left with now is, what do we do about this? One answer here is ensuring that we design and plan and execute interventions that are culturally tailored. Kenita Hobart in 2025, she's a behavioral scientist whose work focuses on cancer disparities. She wrote about adapting health promotion and disease prevention interventions for specific cultural contexts. Her work on genetic counseling for hereditary breast cancer among African American women illustrates both the promise and complexity of this approach. Standard genetic counseling protocols were developed primarily with white populations in mind. Thus, they emphasized individual risk, medical decision-making frameworks, and traditional assumptions about family communication that didn't always fit different cultural contexts. So, Kenita adapted this approach by incorporating beliefs about spirituality and communalism, cultural values that are more prevalent among African American communities. She integrated these into the counseling process. The results of this integration were better engagement and better informed decision making. But cultural adaptation isn't a linear and simple process. Instead, it requires genuine understanding of the target community, involvement of community members in the design and really throughout the planning, execution, and evaluation process, and a willingness to revise and iterate when something isn't working as planned. Community based participatory research, or CBPR, provides the framework for this kind of work. The core idea here is that communities aren't just subjects of research or recipients of an intervention. They should be recognized as partners and really as being in the driver's seat of defining and implementing these interventions. CBPR is meant to flip traditional power dynamics. Instead of having experts arriving with predetermined solutions, community members are actively involved in identifying priorities, in shaping the design of the study, and participating in interpreting the results. Interventions that are developed this way tend to be more culturally relevant, more trusted, and more sustainable. From my own experience leading different health programs in Colombia, I can say this with confidence that this approach isn't just ethically preferable, but it's also a practical necessity. When we partnered with community-based organizations led by conflict survivors to develop mental health services, the programs looked very different than what outside experts might have designed. They incorporated community gathering spaces, spiritual practices, and peer support models that made sense within Afro-descendant as well as indigenous cultural contexts. And they worked not because we had the right clinical protocol, even though we did pay special attention to the cutting edge in clinical protocols, but the determining factor was that communities had a sense of ownership over their own healing process. CBPR has been used effectively to increase vaccination rates, to improve chronic disease management, and to address a wide range of health challenges across diverse communities. The common thread is ensuring that there's genuine participation and that the partnership goes across the board, that you identify, leverage, and strengthen existing capacities, that you have two-way communication, that you don't inadvertently duplicate and weaken the existing trends of the community. You must not have a token, consultation, or participation. Social epigenetics also have policy implications worth noting here. If biological markers like DNA can register the effects of social inequality on bodies, they might also serve as early indicators of whether policies are working or not. Again, Martin and colleagues in their 2022 research suggest that tracking epigenetic changes would help to evaluate interventions aimed at reducing health disparities, providing evidence of impact at a biological level, not just in self-reported outcomes. This is still fledgling science, but it does point toward a future where we can measure the embodied effects of policy decisions, holding systems accountable for their impact on bodies, not just on budgets. And wrapping up, we have covered a lot of ground, not just today, but over the last 4 modules. We discussed the whole spectrum of cultural competence, humility, and safety. We discussed acculturation and heritage consistency, the stigma of mental illness, and the effects of migration, both forced and voluntary. We looked at systemic racism and its effects on intergenerational transmission of trauma. We considered traditional healing practices and epigenetics. We also looked at the cycle of prevention, treatment, and rehabilitation. And we looked at pandemics, most notably COVID-19, and global health policy. If there's one thread running through all of these things that we've discussed, it should be, I believe, that a culture is not an obstacle to be overcome, but it's the context within which health happens. It's the ocean in which we swim. Every behavior that may appear irrational to an outsider may be sensible from the inside. Vaccine hesitancy may reflect a historical trauma. Missed appointments may signal transportation barriers or mistrust. Non-adherence to treatment may reflect belief systems that weren't engaged. When we approach communities with the assumption that they're wrong and they need correcting, we are destined to fail. Instead, when we approach communities with genuine curiosity about what makes sense from their perspective, we have a chance of building understanding. So here are some key takeaways that I hope you will hold on to as we move beyond this course. The first one is that culture shapes every stage of the continuum of care, from prevention to treatment to rehabilitation, and every level of the system, the individual, community, national, and even global level. You can't define effective interventions without paying attention to the cultural context that those interventions are going to be operating within. The second takeaway that I want to stress here is that health disparities are not accidental, they're not coincidental. They are the byproduct of systems, historical and ongoing, that distribute resources, risk, and contain power inequality. Addressing disparities requires critically examining and reforming the systems, not merely educating the individuals within the existing systems. The third takeaway is that communities are not and should not be constrained to being viewed as passive recipients of an expert or an externally imposed intervention that has too long been the norm. And it is not only unjust, it is also ineffective. Instead, communities possess knowledge, resources, and resilience, the ability to confront and recover from a crisis, returning to their original state or rebuilding better than where they were before. They contain these abilities in ways that outside professionals often overlook. This is why the most effective programs are built
based on partnership with the communities and not imposed from above. The next point that I want to make is that policy matters here. The decisions that are made by legislatures and ministries and funding agencies can shape the conditions within which local programs operate. This is why advocating for culturally inclusive policies should be part of the work. And the fifth and final point I want to make, and this one is really important, is that trust is a gradual and carefully earned asset. It is earned not through the discourse, but through the behaviors that are maintained through time. This means that there's no amount of messaging that can substitute for systems that consistently treat people with dignity and respect. And the corollary of that is that trust is very easy to break. So it has to be carefully attended to. And with that, we close these 4 modules on culture and health. Thank you for listening to these sessions. I'm open to any comments. Feel free to engage. And I wish you the greatest success as a more culturally aware and hopefully more culturally humble and thus effective health worker at the community, national, and global level. Thank you very much.